My name is Alice Chu. I'm the Director of Market Access and Medical Marketing for the region, and I will be your host tonight. Glenn Fawcett, our Vice President Commercial, sends his regrets because he's currently at a symposium at New South Wales in Brampton. So we want to welcome you to Glaukos Asia Pacific MIGS webinar series number 2. And today we'll be focusing on iStent Inject W, the surgical pearls and pitfalls. Now, with a million iStent technology stents implanted globally, we certainly do have some iStent Inject masters within our region. And 2 of them are here tonight from Singapore. That's Dr. Bryan and Professor Shamira Pereira, who will share their surgical expertise in implanting iStent Inject and W and their troubleshooting approaches. So first up is Dr. Bryan. He's a consultant with the glaucoma service at Tan Tock Seng Hospital, and he's the fellow of the Royal College of Ophthalmologists. He is one of the earliest adopters of MIGS in Singapore and is proficient in all the non-blood forming and the blood forming implants. Now, his MIGS skills were recognized by winning the 2nd best video at the World Glaucoma Congress in 2019. And by the way, that was for iStent Inject, and also best video at the American Academy of Ophthalmology in 2021. So he is heavily involved in speaking engagements and in evidence generation with over 30 publications. Now, if there was a Forbes 40 under 40 for glaucoma, Dr. Bryan would definitely be on that list. All right. So second up is Professor Shamira Pereira. He is a senior consultant in glaucoma service at the Singapore National Eye Center. Now, Professor Shamira's accomplishments are too long, so I will highlight some interesting points. He's an innovator. As co-head of bioengineering and devices at the Singapore Eye Research Institute, he's commercialized a few glaucoma and cataract prototypes, and his group has won a prestigious National Engineering Award. And Prof. Shamira loves to teach. He has developed an award-winning free app with touch surgery on teaching cataract surgery, and he's been voted as outstanding faculty and teacher mentor. Well, we are lucky for that today. And of course, Prof has also lectured around the world and has produced several book chapters and has published over 150 scientific publications. Now, during the talk, we encourage you to type your questions into the Q&A box at the bottom, and we will address them right after the talks. So thank you. Bryan, I hand it off to you.
Thanks very much, Alice, for the very kind introduction. I'm just going to be sharing my slides with everyone now. I trust everyone can see my slides. Hi, good evening, everyone. I'm Dr. Bryan from Tan Tock Seng Hospital in Singapore. And I'd like to thank Glaukos for inviting both Dr. Shamira and myself to speak on the topic of surgical pearls and pitfalls for the iStent Inject W. These are some of my financial disclosures. Now, over the next 20 minutes, I'll be covering first a quick overview of the iStent Inject W, followed by surgical pearls as well as surgical pitfalls and how to manage them. So first, a quick overview of the iStent Inject W. I'm sure most of us will be familiar with minimally invasive glaucoma surgery, or MIGS, and these are some of the MIGS that we perform in our center in Singapore, from the iStent Inject, the iStent Inject W, of course, the hydrous microstent, and all these really are angle MIGS or angle-based MIGS surgeries, as well as subconjunctival MIGS surgeries, including the Zen 45 gel stent, as well as the PreserFlow microshunt. There's a whole spectrum of MIGS surgeries, but all of them share some common characteristics. And this would include, firstly, a micro-invasive approach, minimal tissue trauma, a more rapid recovery, and a higher safety profile compared to traditional glaucoma filtering surgery, and finally, at least modest efficacy. Now, Glaukos has been very impressive in really pushing the envelope when it comes to angle-based MIGS surgery or trabecular mesh bypass surgery, starting first with the first generation iStent back in 2012, followed by the second generation of the G2 iStent Inject in 2018, and of course, most recently, the iStent Inject W in 2020. And for those of us who are familiar with both the iStent Inject W and the G2 iStent Inject, you will know that the main difference, or the only difference in the device at least, is with regards to its flange, with the iStent Inject W having a larger, wider flange of about 360 microns in diameter compared to 230 microns in diameter for the G2 iStent Inject. And this is envisioned to reduce the risk of overimplantation, as well as to increase predictability and consistency in implantation. And this has indeed been my own experience as well. But it's not just improvements to the device, there have been modifications to the injector system as well. With the iStent Inject W injector system, there's now a shorter window with a bridge that optimizes visualization of not just one, but both stents. The trocar tip is now tri-beveled compared to the previous rounded tip, and this is supposed to reduce tissue tethering and reduce the risk of underimplantation and accidental dislodgement of the stent upon withdrawal. And also now the stents are placed relative, one inside the collet and one just outside it, again, to improve visualization of the stents. And overall, the injector system, as well as improvements to the device, is designed to enhance visibility, to facilitate seamless placement, to provide a more observable positioning after implantation, as well as to deliver more procedural consistency and predictability. I'm just going to show you now a standard implantation of the iStent Inject W, and this actually is my very first case, of course, on the back of performing the iStent Inject G2 for a couple of years. For those of you who have done both surgeries, you will know that the transition from one to the other really is very seamless. The steps of the surgery are all very similar. They're all the same. And here, as you can see, I actually perform my W implantation before my phacoemulsification itself. I like to visualize the angle of the eye before I implant my stent or before I open the delivery system. I like to go for the more congested areas of the trabecular meshwork itself, as what you can see here. I'm not increasing the speed of this. I'm not slowing it down. I'm showing this to you real time over here. As you can see, I'm just implanting the stent into the trabecular meshwork. I like to impale the trabecular meshwork with my trocar in the precise area which I want to implant my stent in. After I implant my stent, I like to withdraw very slowly out of the trabecular meshwork itself. Here you can see I'm going for the second congested area in the trabecular meshwork. Again, doing it very slowly and deliberately, releasing the stent and withdrawing my injector system very slowly. And when I have time, I like to decompress my eye itself, lower the pressure, and hopefully I get to see some blood reflux from the lumen of the stent, which you see here in my second stent. For the first stent, I create some turbulence and I flush the lumen of the stent a little bit with some VSS, and immediately you see the flow of blood reflux, again, from the lumen of the iStent Inject W. And this really is a standard implantation procedure for the iStent Inject itself. Now, I dive straight into some surgical pearls and pitfalls, which I have come across over the last couple of years in performing the surgery. The first surgical pearl I would like to share with everyone today is the importance of planning and preparing for your iStent surgery. Now, firstly, we need to rationalize patient selection. We know that the iStent Inject and the W is FDA approved to be performed in primary open-angle glaucoma, in eyes with mild to moderate disease. And this is really what I call the sweet spot in terms of patient selection. These are patients, in my practice at least, who are most likely to benefit the most from these surgeries, such that they are medication-free after implantation itself. And of course, it's performed in combination with phacoemulsification. And I approach this as a phaco plus procedure, and my patients are obviously very open to this implantation together with their cataract surgery itself. Of course, this is not to say that implantation in other glaucoma subtypes are contraindications. They are merely off-label. But my center has published some data demonstrating efficacy in a mixed bag of eyes as well. Also in normal tension glaucoma, in a retrospective as well as a prospective case series. And we also presented some data on double iStent Inject implantation in more advanced glaucomas, again in a mixed bag in some conferences, demonstrating mixed results as well. It's important to have a clear temporal cornea. When I first started my iStent surgeries, I thought that it was the nasal cornea that was important, but actually it was a clear temporal cornea that was more important because this was where your line of sight would go through as you are approaching the nasal angle. And of course, you would like a visible angular anatomy. You like to delineate all the structures of the angle itself and a pigmented trabecular meshwork. This is how the iStent Inject device is supposed to sit in the angle. And of course, you would know how to achieve this only if you're very clear about the angle anatomy that you identify intraoperatively itself. It's important to position yourself well for intraoperative gonioscopy to achieve essentially an on-fast view of the angle. The best way to achieve this really is by good and adequate positioning and tilting of both the microscope as well as your patient's head. Here, I'm just going to superimpose on top of a still photograph of one of my angle mix surgeries. You can see here, this is the perpendicular line. I'm tilting the microscope towards me by about 30 to 40 degrees and tilting the patient's head away from me by about 35 degrees. And this, you can see in the background over here, is what you should be seeing just before you put on the gonial lens itself. Well, secondly, it is important to aim for an ideal depth of implantation. An ideal depth of implantation. Now, the question I often get asked is, does the depth of implantation actually matter? Well, this is a very good study published in 2019 in the Journal of Glaucoma. This study essentially examined the positions of iStent inject G2 using optical coherence tomography. And this is a very nicely well-positioned stent. And these are pictures of OCT scans of not so well-implanted stents. This is a slightly under-implanted stent. These are slightly over-implanted stents, and this one is entirely within the angle itself. There's probably no connection at all with the anterior chamber. And this study unsurprisingly demonstrated that good positioning of the iStent was associated with better IOPs as well as greater Schlemm's canal dilatation after surgery itself. This was an earlier study demonstrating, again, very expectedly, greater dilatation of the Schlemm's canal when the head of the iStent inject G2 device was nicely placed in the canal itself. And how to do this is to avoid underimplantation, which, as you know, is more common than overimplantation, particularly with the improved W device. You can avoid underimplantation by one of two ways. The first is to avoid trocar bias. Now, what is trocar bias? This is a photograph of an iStent inject delivery device with its trocar anchored in the trabecular meshwork of a model eye. And you see here, the trocar is equidistant from both ends of both sides of the barrel of the injector system. Now, what happens if you skew or if you move the iStent injector in one direction or the other, like in this case? Well, you see here then that the distance between the trocar and each side of the barrel is not equidistant anymore because the trocar is anchored in the trabecular meshwork while the injector system is being skewed one direction or the other. Imagine what happens then if this happens while you're withdrawing the injector system after implanting the iStent. It is likely that you may accidentally dislodge the stent or you may cause underimplantation. So it is important, therefore, to avoid trocar bias. The other way to avoid underimplantation is to withdraw the injector slowly and along axis of implantation, like what I'm demonstrating over here. You can see I've already released the stent, but only half the petal is won. I still need to withdraw the injector system very slowly away from the angle itself to ensure that I do not dislodge the stent or pull it along with me as I withdraw the injector system from the stent itself. The third part I have with everyone is to consider targeted placement. Now, what is targeted placement? Well, what we do know today is that angle makes increased segmental aqueous outflow. We know this through a number of studies on trabecular meshwork bypass devices, as well as with bank surgery or bent-ab internal needle goniotomy surgeries. And these studies have shown that angle makes the increased aqueous outflow in these segments of the eye. But what we unfortunately do not know is the specific distribution of collected channels around the 360 angle of the eye. And we know that the collected channel distribution, unfortunately, is not equal around this 360 degrees. And what we do know that the collected channels are perhaps more dense in the nasal and inferior quadrants of the eye. There are still many areas within these two quadrants to place the iStent inject device in. And so the question we should have is, where specifically in the trabecular meshwork in these areas should we target? Well, I have three suggestions for everyone. Firstly, we can consider targeting the more congested areas of the trabecular meshwork. Like in these stills from my own surgeries, you can see here that I'm targeting the more congested areas of the Schlemm's behind the trabecular meshwork as opposed to the paler, less congested areas surrounding them. And the rationale behind this is straightforward. We assume that these areas are more congested. The Schlemm's canal behind the trabecular meshwork in these areas perhaps more congested, they're more dilated, perhaps with greater flow, and perhaps this would allow greater effect or efficacy of the iStent inject delivery devices. The second method that we may consider is to target the more pigmented areas of the trabecular meshwork, like what I'm demonstrating over here. And again, the assumption behind this is that areas with greater pigments have greater pull of the pigments into that area of the TM. And why that's so is because of the greater aqueous outflow in that particular segment. Now, this has not been definitively proven, but it has been shown in very early studies back in 2001, this one by Gotanka et al., which demonstrated that areas of the trabecular meshwork with more open inter-TM spaces have a greater density of pigment granules compared to other areas or other segments of the TM with more closed inter-TM spaces. These areas were found to have less pigment granules. And therefore, there's a suggestion perhaps that areas of the TM with greater flow may be associated with more pigmentation. However, this has yet to be definitively proven. And finally, we can consider targeting areas which correspond to more prominent episcleral vessels. Now, we've been studying the anatomy of aqueous veins and episcleral vessels for many years now. This is taken from 50 to 60 years ago. But what we do know more now today is that in fluorescent aqueous angiography studies, they have shown that there's greater signal in areas which overlap episcleral veins. And so it might suggest then that we can consider identifying, marking out more prominent episcleral vessels, marking out at the limbus where targeting the TM would probably reach them, and then implant these iStent inject devices in these areas. Anecdotally, in my experience, many times actually these corneal marks that I make with respect to the episcleral vessels do correspond actually to the more congested areas in the trabecular meshwork. Perhaps there's a suggestion then that iStent inject delivery or implantation in these areas might possibly have greater efficacy. The fourth pull I have is to attempt more than 2 o'clock hours separation of stents. The concept behind this, of course, is the hope that we want to catch as many collector channels as possible, and separating your stents as widely as possible would perhaps catch more collector vessels or more collector channels. How do we do this? I'll demonstrate this with a simple schematic. Now, this is an eye in which the surgeon is implanting the iStents in. That's where the surgeon is looking through. That's the corneal wound. These are the iStent inject devices. Now, what if I want to place an iStent inject device a little bit outside these two areas over here? How do I achieve this? It's difficult to achieve this with all these parameters remaining the same because it's simply just outside the wound. Well, very simply then, and I'm exaggerating it a little bit in this photograph, but you can have a larger wound. In my practice, for example, I perform small incision phacoemulsification with usually a 2.2 millimeter wound, but in my iStent inject surgeries, I usually use a 275-2.8 wound. Just hold that I can have a little bit more of this excursion and implant the stent a little bit further out than where I would normally do them in a smaller wound. If you want to maintain that same size of the wound, like in this case, for example, how do you still then achieve implantation of a stent that's just slightly further out? Well, you simply shift your microscope. You sit further away, and you can imagine then that through that same length of the corneal wound, you can implant that stent further out from where you would normally implant them. So you can attempt more than 2 o'clock hour separation of stents by either having a slightly larger wound or simply shifting your microscope. The fifth pull I have is to recognize signs that demonstrate good iStent placement. So having done all that, how do you know your iStent has been placed well? Well, there are a few signs that will tell you this. The first is a good blood reflux. And emphasize that the blood reflux has to come through the lumen of the stent rather than just adjacent sides of that stent, like in this case over here. You can also look for episcleral venous blanching. Here I've implanted 2 stents here. You can see there's already some reflux to the lumen of my second stent. And I'm going to just hyperinflate the eye a little bit and look for episcleral venous blanching. And you have to pay attention to catch this. I just pause the video here so that you can identify and you can spot this vessel over here. And as I hyperinflate the eye, you see this vessel blanching very quickly. These are where I put my 2 stents, and these are the corresponding blanching areas. I'll show that again. This is the first vessel. You see that blanching very quickly, probably to the stent here, and this one through the stent on the other side. This perhaps could also signify much greater flow, probably through your iStent inject devices. And finally, if you have the intraoperative OCT, you can also ensure that your stents are very nicely placed, like in this case over here. You can see I'm just imaging these stents. You can see the distance between the flange and the trabecular meshwork is optimal. You can see the lumen of the stent, and if you look carefully enough, you can even see some reflux bleeding from the lumen of the stent itself. And this is where you can be very confident that you've neither over-implanted nor under-implanted your stents with the use of adjunct imaging devices. So the surgical pulse I'll share with everyone today: plan and prepare your surgeries, aim for an ideal depth of implantation, consider more targeted placement, attempt greater separation of your stents, and recognize signs that might demonstrate good iStent placement. In the next 5 minutes, I'll go through very quickly some surgical pitfalls and how you can manage them. Occasionally, as I mentioned, you might get under-implanted stents. Well, what do? Very simply, you can just tap the stent in. Well, this is an example from the G2 stent over here. You can see I've under-implanted a little bit. You can see a bit of the thorax of the stent behind the flange, which you really shouldn't be seeing. It should be really embedded in the angle itself. I like to normally go on to my second stent before going back to deal with the first one. I'm implanting my second stent very nicely here, going back to the first. And the concept of this is a very straightforward tip of needle to lumen approach. So it's a tip to lumen approach. Importantly, you must do this in the axis of the iStent inject device to avoid dislocating or dislodging it inadvertently. This is a more obviously under-implanted stent. You see here not just the thorax, but even a little bit of the head that's still peeking out of the angle. Again, tip to lumen approach, aligning it to the axis of the stent itself and what it looks like before and what it looks like after tapping it in. With the iStent Inject W, I'm happy to say that it's much easier to do this tapping in because you have a broader needle tip and a larger flange, as what I'm demonstrating here. This is the tip of the needle for the G2 stent, and this is the G2 stent itself. This is the W stent with a wider flange and a more rounded needle, and this allows you to tap it in much more easily. I'll demonstrate this here. It's not really under-implanted, but you can see how easy it is to aim or to target that much wider flange over there. The second surgical pitfall, the free-floating stent. Now, occasionally, you might accidentally dislodge that stent into the angle. Well, it's all lost. No, it's not. You can simply reload the stent and re-implant it in the angle itself. And the first thing you need to do really is to orientate the stent such that the lumen faces your trocar. Once that's done, you thread the trocar through the lumen of your stent, like you thread the pole through rings. Once you've done so, and once you've caught the stent, bring it to an alternate location, have just gentle indentation into the angle itself, and then implant your stent. And you see there, we have successfully resuscitated or salvaged a free floating stent. We have two very nicely well-placed stents in the angle now. Alternatively, you could reload it outside the eye. Here, I'm just using microforceps here to just remove the free floating stent, putting it on a white clear surface outside the eye. And again, the same concept of reloading the stent by threading the trocar through the lumen of the iStent exit device. Remember to extend out the sheath of your needle over the hub of the injected device to protect the stent so that you don't lose it on the way back into the eye. The third surgical pitfall, what happens if you have a stent that's over-implanted? Well, the next clip is an extract of a video that we submitted and won second prize for at the World Glaucoma Congress in 2019. Well, very simply, you can extract, reload, and reimplant the stent itself. These are some examples of over-implanted stents. You can see you've lost the stent entirely. You don't see the flange anymore. In this case, for example, there probably isn't even a connection between the stent and the anterior chamber. This is another case here. The view does not help. You see the cornea striae. You lose view of the stent almost immediately. It is over-implanted. Well, it's all lost? Not really. What you can do is to extract, reload, and reimplant the stent. And I'll show you with two cases how we can do this. Well, the first thing we can do, and the first step in this process, is really to circle around the circumference of the stent. And you're doing this to expose the flange of the device, which you had previously lost. You want to pull the trabecular mesh tissue away from all the sides of the device. And once you are confident and satisfied with the view of visualization of the stent, you want to extend out the sheath of your needle, snuggle it between the stent and the trabecular meshwork, and attempt to flip or tumble out the iStent, as you can see I've done here. And following this, you can just follow the same principles I demonstrated earlier of reloading and reimplanting the stent. Now, this is the second case where the overimplantation is more severe. The stent is much deeper than the earlier stent you saw. Here, I'm doing a lot more work, but it's the same principles again of using the trocar of your delivery device to pull the trabecular mesh tissue away in all directions away from the stent so that you adequately expose the flange and as much of the stent as possible. Now, after you've done this and you are satisfied with the view, extend out again the sheath of the needle of your delivery device and attempt to tumble out the stent. And again, this is more difficult than the first case because it's much more buried, but with some patience, you get it done. Occasionally, you might cause some bleeding around the area. But not to worry, once you have tumbled out the stent, you just need to move it to a clearer area away from the blood, and again, reload and reimplant the stent in the same fashion as I demonstrated earlier. And this is how we resuscitate an overburied or overimplanted iStent. But what if the stent is overimplanted but not so deep? Well, in this case, for example, you can see it's slightly overimplanted, but it's not as deep as the cases I showed you earlier. Well, you simply need to clear the sides. And what I mean by that is just clearing the tubercular mesh tissue away from the flange of the device. And why this is important is if you leave it like that over a couple of months, in my experience, what I observe is that the tubercular mesh tissue grows over the flange and into the lumen itself, thereby affecting or reducing the efficacy of the stent. You can see here I'm just shifting away and scraping away the tubercular mesh tissue. You can see here the flange is much more visible here right after surgery. And this is the same eye 3 months after surgery. You can see the flange is still very visible. You can still see that clearing around, and you can still see very good efficacy. Patient is off 1 drop and a reduction of 2 millimeters mercury of IOP over and beyond the medication reduction as well. My fourth surgical pitfall, what if you have no shots left? Occasionally, you have used up all the shots in the device, but you still have a free stent that you cannot implant. Well, what you can consider is to manually push it in. Now, I only recommend this in the situation where you can successfully identify the cleft that you created earlier when you were attempting your early implantation. If you do not identify that cleft, if you cannot see that cleft, you cannot manually push the device in. It's simply not pointed enough. But in this case, I have identified the cleft, and you can see here that I'm just gently easing the tip of the stent into the cleft. I'm being very conservative here, and just to be very sure the stent is in, I'm using a BSS cannula to push it in further. I'm using the irrigation aspiration here to just create very gentle turbulence around the area just to make sure it's very stable. And the stent is very stable, it's not budging, so I know it's very nicely in that cleft. And in this case, I've used the intraoperative OCT again just to confirm very nice optimal placement of the stent. You can see here, it's not under-implanted, it's not about to fall out, it's very nicely placed at the end of surgery. And this is that same patient, 4 months after surgery. You can see the edge of the cleft over here. The stent is very nicely placed, definitely not dislodged, not under-implanted, very good efficacy as well. And finally, you can pass it on to another delivery device. Like in this case over here, I'm shifting the stent from one delivery device to another, again, threading the trocar through the lumen of the stent. Make sure that you put back the sheath of the needle before you re-enter the eye. And here you have it, a resuscitated stent. And so my final slide, how to deal with surgical pitfalls. If it's under-implanted, very simply, just tap it in. If it's free-floating, you can reload it and reimplant it, reload it in vivo or ex vivo. If it's too deep, you can extract, reload, or reimplant the stent. If it's not too deep, you can just simply clear the sides. If you have no shots left in the delivery system, you can manually push it in if you can identify the cleft you created earlier, or you can simply just pass it on to another delivery system. I hope this talk will help you in your iStent Inject W surgeries, and I thank you very much for your attention.
Okay, thank you very much, Bryan. That was a fantastic talk. And I was really impressed by the fact that you have such clear videos. I think this is a real testament to the fact that we need to get people to really upscale the level of their video taking. And I'll just go and get my talk ready. Okay. So I'll be talking about the iStent W surgical pearls and pitfalls, fairly similar to what Bryan has spoken about already, but I've got a different tack to this. And I think it's very interesting that, a lot of things that Bryan said, I totally agree with. And the fact is that, we came to these conclusions through completely separate journeys. And I think all I can say about that is that great minds think alike. My journey through MIGS has been, for the last 7 years, a really interesting one. I think, we've been very fortunate to have MIGS in this area very early. And I think one of the things that we have really pioneered is the fact that you can learn from one MIGS onto another. And I was very fortunate to be involved with Glaukos from 2016. And I actually went to their training center in Armenia to learn how to put in the G2. That's the original device that we trained on. What I'll be going through today is mainly about the iStent Inject W, but I think I'll be showing a few pearls and pitfalls from the iStent Inject as well, because they're very similar devices, realistically speaking. Here are my financial disclosures. I speak for many of the MIGS companies, and hence I've got a good overview of what else is out there in the market. So let's talk about my first video. Everything here is going to be videos, actually. So you'll be, it's a time to just relax and just strap in to your seat. There's going to be just a whole load of videos. And this is going to be basically showing you the different views that you get with the Swan-Jacobs and the iPrism. You can see the two on either side here. I think the Swan-Jacobs gives it a touch better view because it's a glass prism, it's mirrored, and you get that extra level of light transmission and you get extra clarity. This is just on the same patient, same surgery, just one prism instead of another. The iPrism is also very good. It gives you that slightly wider view. But I think for those starting off, you probably better start off with the Swan-Jacobs prism. Moving on, if you've only got the availabilities for an iPrism, that's absolutely fine as well. But it does take a little bit of extra effort to learn how to use this compared to the Swan-Jacobs. Here's a good G2W with reflux. Okay, here we go. So this is a G2W going in here. And you can see the reflux straight away. Next one goes in 2 clock hours later on. And you can see that, yeah, a bit of stry on the cornea, but otherwise not too bad. And you can see actually good reflux straight away. Here, I'm just depressurizing the eye. You can see the reflux of the blood straight out through the area. And once you put pressure up, the blood goes back. And when I decrease the pressure inside the eye, yes, you can see very nice reflux of the blood into the anterior chamber. So these are definitely in the right position. So that's a good one. And I think it's important to go and show that this is actually what mostly happens when you've got into the zone of getting these things in repeatedly and predictably. Now, the remainder of my talk, as opposed to Bryan's, actually is going to be a little bit more about the complications and how to deal with them. They're not common, but I think it shows you what can go wrong. And I think, as always, the better you are forewarned about these things, you're better forearmed. And I know this is quite a senior audience, so I make no apologies for the fact that these are quite difficult moves to make, but actually do pay off because you guys are all very experienced at putting in stents already. And I think, a real credit to Bryan is the fact that some of the things that he was showing, he makes it look so easy. It really isn't that easy, but I think with a bit of practice, we can all aspire to be as good as Bryan. So here's another one. You can see the stent going in, gentle pressure for the first one, a little bit of indentation. It looks pretty good, okay? Maybe a little bit over implanted, it's a bit flush there, but you can see the lumen is clearly free. Moving across 2 clock hours, you put the second one in. And you can see that one is probably a little bit, as Bryan was saying, a bit under implanted, but you can actually just tap it in. And what Bryan was saying was exactly right. The new fit of the new injector system really suits it very well, and you can get it just in perfectly with a little tap. That's all it needs, and it fits very nicely actually. Here's another one going in, and I think it behoves us as glaucoma surgeons to get this right and not just leave it as it is. I think here's an example of one going in and going across 2 clock hours. Second one, you need to go and push a little bit harder because the forces generated by the injector are not as great. Here, again, you can see you've got to pull out in a straight line. Otherwise, you do tend to sometimes pull it out. In this one, I'm using the same technique as what Bryan used about just pushing it into the right position. And you can see that you get a good result with both stents producing blood. Here's another one, checking the iStent. You can see putting the infusion aspiration right up to the stent to make sure it's totally stable and the lumen is clear. Once you're in that position, you can be happy that it's going to be working. Here are some examples of what can go wrong. But this is a very, very shaky placement, but actually, it actually goes very well. So you'll see it here, injecting into the trabecular meshwork here. And actually, that's a great placement. Move across 2 clock hours, and you can go, again, remember that lack of bias there is very important. And you pull out straight out, and it's a great placement there. Beware of the sideways tilt. This is what Bryan was talking about with the bias. You can see here, there's clearly bias here. It's being pulled over to one side. What happens is the forces are not correct, and the stent seems to bounce off the sides, doesn't go in correctly. Here, again, there's a lot of bias there. Now it's corrected, and you need to get a straight path of the stent to go in. And when it does that, you can see nice efflux of blood from stems, and that's fine. Here's an example of overestimation. And the reason why this is overestimation is because the view is wrong. You can see that the eye is not on fast towards the trabecular meshwork. And with that kind of glancing view, it frequently ends up as over-implanted. Here's a one where the G2 is stuck to the needle. Seems like it's pulling it all the way out again, but actually it leaves it in a decent position. It's actually okay. Here's one where there is a immediate bleed, but you've got to be confident about where you put it. So even if it bleeds immediately, you lose your view, you've pierced in the correct position, you can just let go, put the next one in next door. And even this one bleeds as well. And you lose the view, but you are confident about your positioning. When you get rid of the blood, you can see this perfectly placed iStents. And with reflux beautifully out through the lumens when you decrease the pressure. And that's the kind of ideal result that you want to achieve all the time. Here's another one with a G2W adjustment. Goes in, immediate bleed. You can't see the iStent at all. Next one goes in. Looks a bit better, but still a lot of blood around. But when you have a look around, yeah, you can see that there's actually a good insertion. Okay. How about you dealing with the problem that we talked about earlier? What happens if you've got too superficial an insertion? And Bryan showed this very well. You can actually take the iStent out. Now, threading, you can decide to do in the eye or outside the eye. I'll show you an example here, what we decided to do. See this stent here? It's not implanted correctly. So flip it out exactly the same way that Bryan showed earlier on. And you can choose to either rethread it inside the eye. Here I'm trying and struggling because it's like in mid-air. But actually it's a highly edited video, but actually I do manage to go and pierce it through. And I've got a few more shots left. So I can actually move across and reimplant it. Sorry for the stry here. Eye is probably a little bit soft at this point. But nevertheless, managed to move across to a different point, push a little bit harder this time, pierce through and let it go, and it goes in the right position and is perfectly inserted and not too superficial. Okay, now moving on to a bit more exotic things. Now, we've all seen that actually these stents are very, very safe in the eye. And you can see the complications that have occurred in the LJ CAT study, actually very, very small. Interestingly, the complications really do increase with closed angles. And one of our colleagues from Singapore, Dr. Cheng, he did a study on the occlusion of the G1, and it increased 31% in closed angle eyes compared to the open angle eyes, which are only achieving 4%. So this is a specifically difficult group to do. And of course, this is off-label use, but we're particularly interested in this area because there's a lot of angle closure in Singapore. So I'll show you how we deal with this in this particular region. Bryan showed some excellent examples of why we want to go for the perfect placement. And you can see some examples of poorly placed G2s in this particular scenario here. You can see the first one is not even in the trabecular meshwork, it's too anterior. The second one probably is in the right place, but actually it's probably over-inserted, probably covered by a membrane. What you want to see is a picture like that ASOCT above of a G1, which is perfectly in Schlemm's canal. Now, Bryan said earlier on that we don't know where these collector channels are. And it's true, but I think the new vanguard in glaucoma diagnosis will be in delineating where these areas are and for targeted placement, because that will lead to the best results. The position of the iStent is really crucial. And I think, it behoves us all to look at the angle in much more detail. And I can personally say that I've never looked at the angle in so much detail as I do now when I'm putting MIGs in under the microscope, in the operating theatre, or even looking at them post-operatively in the clinic. Here's one with a G2W with nice reflux. As it goes in, you can see that, yeah, it's in a perfect position, and there's a bit of blood coming out already. Move over across the 2 clock hours, and the second one goes in, again, in nice position. Again, we want to check that it's in the right position. Second one, probably a little bit too over-implanted, but actually, as you can see, when we look at it, when we're doing the IA, and you see this is a non-gonioscopic view. This is something we call what I published a paper on called the water gonio, where you make a little dam of fluid with your thumb in that triangle, and that creates a prism effect. And you can actually do gonio without a prism, and you can have the IA on board there, and you can see what's going on. And you can actually have your second hand free, completely free, if you ask your assistant to dam the fluid up there, so you can see what's going on. So here's another one with nice reflux. Coming out there. Okay, that's the kind of picture you want to achieve. Aim for the brown patches. This is very important because this is probably the area that is draining well. Here I've gone for one of the clear brown patches, but the second stent, I haven't got much of a good view here. And I'm going really to the edge of my view. I'm not going for the white area, I'm going for the brown area, far across, stretching across to get that more than 2 hours separation, but really stretching to find that area of brown. I think that really does pay off in the longer term. In these particular cases, it aimed for the brown areas, but it was still dry, but actually it probably will work out okay. Here's where we use a needle to clear around the G2W for good flow. So you can see the needle being used to delineate that area. Here's another one. Once it's gone in, pull out, but just make sure that it's completely free by using that needle to just scoop around it, 360 degrees if necessary, to make sure that it doesn't get blocked up by any of the tissues later on. Make sure you can position the device as well and see them with that water gonio, as we call it. This is my most dramatic video. It's called Pinball Wizard. You can see with the first insertion, it looks good. Blood coming out. Second insertion looks a bit underimplanted, doesn't it? I still carry on, and you can see that with the IA, it starts moving around a bit. You see that? Tugging and moving around a bit. But here it starts moving around the whole AC. Here it is in slow motion, moving around the whole AC. And it's like a pinball inside the anterior chamber. It will land on the iris, and you've got to grasp it here with a Kawai forceps to take it out of the eye. And just like Bryan showed you, re-implant it on the needle and put it into the eye with much greater force this time to make sure it doesn't come out. And in this case, actually, we did what Bryan said as well, put it onto the second injector, and we've got a few more iStents as well to put in, just to make sure that it works out perfectly. Here's another one with good efflux via the lumen. When you put it in, press a little bit to get a bit of dimpling, and you gently pull back out again. Do not release just yet. You can see there's some flow straight away, just there. And the second one goes in a similar kind of positioning, 2 clock hours down the line. But of course, you need to give a little bit more extra thrust so you will penetrate through into the TM, because the injections are not given the same amount of power. Now, here's where it gets a bit more crazy again. Here's an eye with eye syndrome. You can see that there's a high PS all the way around. And this is clearly off-label use, but we're trying to go for the one free area, which does look quite juicy, I must say. Once you've got the PS off, we're actually not including the TM there high up towards the SL. We can put a iStent in this area. And I think this was probably one of the extreme situations that I've done this in. And you can see here, we can aim for an area of red with pigment and go for the insertion like we would normally. I've always said, actually, if the injector doesn't ever make it as a good device, you can always use this for a good GSL instrument. So here we go. Both are in the right position. And this actually worked. Actually, it didn't work very well on that one. You see, it's still not come out properly. So I re-implant this with a greater force this time. And this one goes in very nicely. So the question remains, will the PS reform? And I think the jury's out on this one, whether it will be any use. And of course, you've got to remember, we can't do any harm. So it's very important that we do make sure that we're picking our patients correctly for all these cases. Okay. Finally, I'll just go to my conclusion, which is the learning curve is transferable for MIGS. And what we learn on one MIGS can be used on the next one, definitely. I'll ask Christy to confirm that prices may drop or will drop with competition. And we still need some more evidence on these, and there will be some more RCTs and comparisons between devices in the future. I've tried every single shortcut that you can think of with MIGS, and especially with some of these TM devices. And I found out that shortcuts don't work with these MIGS. So best to stick to the rules, especially when you first start, and get a good result. So with that, thank you very much for your attention, and you can follow me on FacoFlix with some more videos like these about MIGS of all kinds. Thank you very much for your attention.
Thank you so much. So I guess when there's a will, there's a way, right? With pinballs and all. And Dr. Bryan and Prof. Shamira has shown their way and their will for sure. So the audience, if you have any questions, we encourage you to type it in the Q&A box. But what we will do is start with the four here. Let's start with Dr. Sonia Morthy. She has a question. I think both Prof. Shamira and Dr. Bryan, you could help answer this. She asked, what are your tips for myopic eyes, as there's more propensity to bleed if the anterior chamber and angle are underfilled? So that's the first one. And then for open angles with anterior iris insertion in the trabecular meshwork.
Bryan, do you want to go with this first?
Yeah, okay. Thanks, Sonia, for the question. I think it's a good one. So your question is with regards to specific eyes and situations where the eye is a lot softer, right? And there's going to be a lot, sort of a higher risk of bleeding. And these are highly myopic eyes with a longer axial length, post-retractomized eyes, for example. I don't foresee a problem with implantation itself. I think we used to think that over-implantation, there's a higher risk of overimplantation in highly myopic eyes. I personally don't really find that. And in any case, the W iteration of the iStent inject really reduces that risk anyway. If you're talking about bleeding after implantation, well, that can happen, but that's easily countered really by just inflating the eye and leaving the eye a little bit more firm at the end of surgery. If you're really concerned, you can consider withholding blood thinners, but I don't think that's absolutely necessary either. I do get microhyphema occasionally on the first day, the first couple of days, but they've all resolved with just conservative watching. So I don't think it's a big problem, this bleeding. You just need to fill the eye a little bit, leave the eye a little bit more firm at the end of surgery itself. Because your second part of your question about open angles with anterior iris insertion to TM, in the eyes that I've seen, I think in implantation of the stent, two things are very important. You need a clear view of the trabecular meshwork. So you need a clear view because you need to know exactly what you're implanting the stent into. The second thing that you really need is you need an intact TM. And why I say that is sometimes in our zest to, for example, do synecholysis or focal PAS, for example, or remove iris insertions or high iris, that's really quite tough. You can damage the trabecular meshwork in that area. And once you have, I'm not confident in putting the device in that particular area. I'm afraid of dislodgement on implantation. It's not stable. So you need to see that segment of TM and you need an intact segment of TM. So you would want to achieve these two basic prerequisites before you implant the stent in that area. I think that's the best way I can answer that question. Yeah, Shamira, your thoughts as well.
Yeah, thank you. I agree with that. And I want to go further on that about these myopic eyes, these highly myopic eyes. Actually, I think the iStent might be the best TM-MIGs for these scenarios, because if you look at some of the other devices, let's say the KDB, the Hydrus, and the ABIC, it's not so easy to do it in these highly myopic eyes at all. And actually, there are several advantages of the G2W in these eyes. Another advantage of these iStents is the fact that you can be left-handed as well, and you can follow it very easily. Because the same kind of movement is that forward movement, basically. Whereas if you're a right-handed surgeon showing a left-handed surgeon what to do, it's very difficult for them to kind of like extrapolate it to their view if you're doing ABIC or Hydrus or even KDB. So it's just something to think about. But nevertheless, I think that actually the G2W doesn't cause any problems in highly myopic eyes. I think it's a good choice for those ones.
Thank you. All right, the next two questions have to do with gonial lens. So the first one is, do you tilt the gonial lens to get en face view of the trabecular meshwork? Let's start with that one.
I think that's a good question. Thanks very much for that. I would suggest if you want to get a good en face view, don't work on tilting the gonial lens. I think work on tilting the patient's head or patient's eye away from you. And as a secondary choice, maybe you're tilting of your microscope, but it's of course much easier to just tilt the patient's head or the patient's eye. I think you can tilt the gonial lens a little bit to help, but I don't think that's really going to make much of a difference as compared to simply just moving the eye away from you or moving the patient's head away from you. That's my opinion. Yeah.
Yeah, I agree with Bryan that moving the patient's head is actually very useful because when you move the head, you don't have to move the scope that much. If you move the scope a lot, what happens is you increase your working distance. So your arms are outstretched. And when your arms are outstretched, they tend to shake. So that's not a good position to be in. So move the head as opposed to the scope. The other thing about this surgery is actually it's quite forgiving. You don't need to have such an en face view for it to work. For some of the other MIGs, you absolutely must have a very good en face view. Otherwise, the device isn't going in. So I think that's one of the advantages of the G2W in this scenario.
Great. What is the best gonial lens to use?
I think Shamira has answered that question to some extent in his talk. So like him, I like to go for the Swan-Jacobs lens or Swan-Jacobs prototype. There's I think the iPrism OA or the iPrism open access lens, I think from Glaucos, I think that's quite nice as well, and that's a Swan-Jacobs prototype. There are many other types of gonial lenses that are available in the market. There's the iPrism S, I think the iPrism SX, and some of these are quite interesting. They maybe have a narrower or a smaller field of view, but a broader one. And then there's the SX, I believe, is supposed to be able to stand by itself, without you having to stabilize the lens over the eye. And then, of course, there are sort of prism clips as well to help stabilize the gonial lens of the eye. In my hands, I work best with the Swan-Jacobs prototype or with the iPrism sort of open access lens. So that's my own personal preference.
Yeah, I think there are several iterations of gonial lenses now, as we've heard, and some of the things that I think are quite useful is to have it truncated. So truncated means that it's like it cuts off part of the lens, so you've got easier access to your incision. Sometimes it's a bit difficult, and you can't get the device in because it's covered by your gonial lens. I think the other factor that's important is making sure that your whole view is taken up by the view that gets through the gonial lens. Don't get a gonial lens that gives you a much wider view, but you don't even use it. I think that's pointless. And finally, the silvering and quality of the material is actually quite important because it gives you the best amount of light projection so that you can get the clearest view. More importantly than any of this is to hold the gonial lens gently. And I'll give you an example. Whenever I hold the gonial lens, the juniors can always get the stents in. But of course, when they start holding the gonial lens and the device together, it gets a bit more shaky. So I think that's the key thing. And if you want to learn on this, just do a phaco, your normal phacos, and put a gonial lens on at the end and try and get the best view you can. And the better view that you get intraoperative on those cases that don't really matter, you'll be well placed for getting a good view for when it counts when you're going to do your first few stents.
Great. Last question. What do you do with a posterior implanted stent?
I think by posterior implanted, I'm not sure whether that means a sort of over implanted stent or it's too deep, or if it's too low. Well, if it's too deep, I've demonstrated the technique of sort of using the trocar of your delivered device to move away the trabeculometric tissue, and then using the needle, getting that needle out to tumble the stent out of the angle itself, and then reloading and reimplanting it. So that's with over-implanted stents. If you're talking about stents that are too low, yes, I've had one or two of stents that are too low, and one, in fact, that's a bit too high, and I've actually dislodged that stent out. As what Shamira has alluded to, and I fully agree, I think it behoves us as iStent surgeons to really make sure that the iStent really works. We know it's very safe, it's very forgiving, but to get the best out of the device is another question, and we really want to do that. And so if I'm not happy with the location of the device, if it's too low or too high, I actually do dislodge it. And that actually takes a little bit of effort, and that's quite a good assurance for us iStent surgeons, because we know that it's not going to just dislodge from the angle itself. So it takes a little bit of effort using the needle to loosen it and then to pull it out of the angle itself. But it is possible, and once it's free, you just need to simply reload and reimplant it again. But of course, it differs from surgeon to surgeon. If you're not as confident to do these maneuvers or techniques, and you leave them there, as I said, it's relatively safe still, and still a very forgiving surgery, but you need to watch for the efficacy of it. That's my opinion.
Yeah, I think I'll just agree with Bryan on that one. It is important to put it in the right position, because otherwise you've wasted a stent, and it's quite a lot of money at the end of the day. And we know that the best placed stents really do work, and a malpositioned stent is really worthless.
Great. Well, right on time. We have 2 minutes left. I just want to close this webinar and thank Dr. Bryan and Prof. Shamira for sharing your evening with us and your tips. So I just want to tell the surgeons that don't forget to sign up for our last webinar of the year, which is scheduled for October 27th, 6:30 Singapore time. We'll have Dr. Shenton Chu from New Zealand talking about his personal data and how it compares to the literature. And we have Dr. Leonard Yep from Singapore, who will talk about how iStent inject fits into his glaucoma management. Thank you very much. Good night.
Good night.
Good night. Thanks, everyone.